posterior corneal astigmatism is a different beast. PCA was never measured till now. What we are measuring is only the anterior curvature of the cornea, the astigmatism, and we are correcting according to that. If there is something in the posterior part which is missed, so recent studies have said that it can vary from 0.5 to 0.8 inherent astigmatism. So which means if my patient has 1.5 diopters of astigmatism, which is with the rule, and there is 0.75 against the rule behind, my net effect only required is 0.75 because the posterior curvature has already corrected. But if I just measure the anterior, and I put a lens according to this, I will overcorrect the patient. Giving an example, let us say a patient's vertical axis is 1.5 diopters more steep than the horizontal.
Right.
So by formula, the multiplication factor is 43.6. So 43.6% more than 1.5 is approximately 2.25. So if I want to correct the anterior astigmatism, I will put a lens of 2.25. For your audience, the multiplication factor is approximately 43%.
43.6.
Whatever lens you are using, on the corneal level, you need to use 43% more for the lens profile. So if it's 1.5 on the cornea, it has to be 2.25 in the lens plane.
Right.
So you want to correct with the rule astigmatism for 1.5, you put 2.25. But there is a posterior astigmatism against the rule, which is already cancelling the 1.5. So the net result is left is 0.75.
0.75.
But what have you corrected? 1.5. The patient will have reverse astigmatism of 0.75. Bad result. And then the surgeon, young surgeon, is wondering what happened. I will not do toric surgeries. Something has gone wrong. What has gone wrong is your understanding. So taking into account the posterior corneal astigmatism intraoperatively also is very important. Now coming to the next step of incision is done.
Right.
Do not stretch your incision. When you're doing surgeries, don't make a lot of movements because when you stretch the incision,
Yeah.
you enlarge the incision. You increase the astigmatism. Your results become unpredictable. Then when you make the capsular axis, make a little smaller capsular axis when you're using a toric lens. So when I use a toric lens, I go for a 5 millimeter axis. Smaller the axis, less chance of lens rotating inside. Another thing is if your axis has extended out and become large, the chances of predictability of cylinder correction are reduced. So rexis is also very important. Next is placement of the lens. When you place the lens, a lot of times you place the lens and by the time you're finishing the surgery, a lens has again moved. Right. So before you finish the surgery, recheck, is the lens where you left it? The trick for that is the lens part, posterior part has sticky surface. So once you finish the surgery, just push the lens back to touch the posterior capsule so that the posterior surface touches the capsule and it doesn't rotate. Last part, please hydrate and seal your incision. If your incision is sealed and doesn't leak, the lens will not rotate. But if the incision leaks, the eye becomes low pressure. With blinking movement, the lens will rotate.
Okay.
Most important, post-toric implant, I recommend for at least 1 hour to 45 minutes, the patient should lie down. So ideally, a patient should be taken out on a wheelchair if you've done a toric lens. Most of the studies says 46% of the lenses will rotate within first 3 to 4 hours.
Right.
So if the patient immediately starts walking, lens will have a tendency to rotate. So ask the patient to be wheeled out, lie down, and go home and lie down for some time. So some study says that surgeons who follow that, there is a stability.
Sir, why toric lenses rotate?
Because see, it is a lens which is doesn't have an anchor. It is a round thing in a round thing.
Right.
The haptics, we will go to the haptic
So
design.
sir, like other lenses like monofocal lenses, they also rotate.
They also rotate, but it doesn't matter.
Yeah, it doesn't have
matter.
axis.
How does it matter? And monofocal lens will rotate. So
Right,
we will
right,
just
right.
see what are the various technologies which are used to make the patients not rotate.